Okay, welcome. I'm delighted to be here and see friends again. As many of you know, this is perhaps my 10th time of having the opportunity to speak before this group. My first meeting was in 2001 in Niagara Falls when we were about 15 people in a little basement room. Had a raffle to try to support the operation, and look how far we've come. So that's absolutely fantastic. So I heard that many people are here for the first time. Could you just raise your hand if this is your first meeting? So, okay, terrific. So knowing that we were going to have a lot of people for whom this is their first meeting, we decided to start off with a review of just what is periodic paralysis, which is the topic of the first talk. And just want to also say I have no disclosures to make. I'm supported by the PPA and some research grants, but have no industry contacts or conflicts for anything I'll be presenting today. So I'd like to start off with your perspective. What is it like to have periodic paralysis? And the fundamental part of this whole syndrome, of course, is the recurrent episodes of weakness. And you should be aware that these come on gradually over tens of seconds to minutes. So this is not a drop attack or something like that. Oftentimes there's a period of apprehension or fatigue that may be the whole morning before an episode of weakness. But the key point is that it's gradual in onset. This progresses to maximum weakness over the course of minutes. That's then followed by spontaneous recovery. So without taking any medication whatsoever, you will get better over the course of hours to a day. And of course, this is one of the really perplexing medical aspects of this condition that's been recognized by over 100 years and has fascinated physicians and scientists to understand, what's going on here. This is very real. This is not a functional illness. This is not somebody who just isn't giving effort. Clearly, there's something intermittently wrong with the muscles, and how is it that there can be this profound weakness followed by spontaneous recovery? The weakness is usually symmetrical, and by that I mean the left and right sides of the body are equally affected. Sometimes it can be regional, so for example, the legs affected more than the arms, and other times it can be generalized. And that's another feature of the condition, that it's variable. So for the same individual at different points in time, not every episode is identical. And of course, across other members of the same family, their episodes might be very different from yours. And for other individuals, even more variability. The severity can range anywhere from you sense something is wrong, you know you're not at 100%, but others in the room don't appreciate the fact that you're experiencing some difficulties, to being severe to the point where you're unable to roll over in bed, can't reposition yourself, can't sit, can't raise an arm or a leg off the bed. So there's a huge range in variability. Fortunately, the muscles of swallowing and breathing and eye movements are largely spared. Sometimes they are affected, yes, of course, but fortunately, they're relatively spared, so episodes of respiratory arrest and failure are extremely uncommon, very uncommon. Another feature of the condition that's really not in the medical literature that I learned from speaking to you all is the pain that's associated with these episodes. So there's a lot of soreness. People say it's like my muscles are all torn up as though I had just run a marathon, that can occur as it's starting and into the recovery period. And that's not well represented in the medical literature, but it's a consistent feature that goes along with the syndrome. So another characteristic feature, besides the fact that there are these episodes of weakness that are variable in intensity but very real, is the fact that certain maneuvers or activities can bring on one of these episodes. And the most consistent trigger factor is exercise. And interestingly, it's really the rest that comes after exercise. So let me show you an example of this. Hopefully the clicker will start. Here goes the video. The captions are in Germany because my friend Ken Ricker sent me this. That says periodic paralysis attack. So this individual has had episodes of weakness throughout his life. Under controlled medical conditions here, he was on a stationary bicycle for 45 minutes and then asked to lie down on this mattress. So it's the rest after exercise, which is the risk period. And he's unable to sit up on his own. He's awake, alert, no sensory symptoms. His breathing is okay, but you can see he's trying to use his arms to help himself sit. Can barely get his leg up. And now, without any intervention, no administration of medications, you'll see how he begins to improve as the video continues here. Notice how his head is hanging forward, so his neck extensors are weak. They're asking him to try to raise his arms above his head. He's not able to. For those of you who can read German, a half hour later. So again, this is the spontaneous recovery. He's now able to raise his arms and even stand on his own. It's a little wobbly there, but you can see a dramatic improvement in strength. And again, this is a characteristic feature, typical attack of periodic paralysis. There's a lot of information out there in social media, on the web. Some of it's good, some of it is not exactly typical of periodic paralysis. This is a classic case. Jake Levitt, who shared his attack from one of these conferences, is also a very good resource to look at. So exercise isn't the only trigger. As many of you know, stress can be a big trigger, either physical or emotional stress, either one of which can release adrenaline, and for people with hypo-PP can trigger an attack. Changes in diet, and we're going to hear later this morning about the influence of diet on periodic paralysis. So it's well known that the amount of sugar intake or potassium can have a big effect, as well as alcoholic beverages. For some individuals, a cold environment is problematic, so people who live up in northern climates go outside in the winter, or in cold water trying to swim or something like that can be a problem. The message I want to leave with you is that as an individual, as an advocate for your own health, pay attention to your triggers. Keep a diary. Don't be over-influenced by what other people say. What do you feel? What do you experience? And by carefully attending to that, you can really improve your quality of life, because with all the science and all the medications that I'm going to talk about, the first line of intervention is minimizing the exposures to trigger factors. And that remains the same today. It's been the same advice for the last 100 years, and for many individuals, it makes a huge difference. I want to talk about another symptom that can accompany periodic paralysis in a subset of individuals with a certain type that I'll mention in a few minutes. And that's sort of the other opposite extreme. So instead of an inability to contract the muscles, there's an involuntary after contraction. So after making a fist, for example, you can't let go. Physicians call this myotonia. It's, again, fluctuates just like the weakness does. The myotonia is most prominent right after a forceful movement, after having been at a period of rest. It lasts for just a few seconds and can improve with repeated activity. This is the so-called warm-up phenomenon. For some types of myotonia, it can be made worse by ingesting potassium or changes in temperature. And as I said, usually within a few minutes of repeated exercise, the severity of the stiffness improves dramatically. So here's an example, on the next video. This is myotonia that paradoxically worsens with repeated effort, which is why it's called paramyotonia from birth, paramyotonia congenita. And it's also exquisitely temperature sensitive. So this individual has had his right arm in a bucket of cold water for about 15 minutes. You can see he doesn't have paralysis. His muscle definition is good. He's able to raise his hands and close both fists. But then when asked to relax, he can't let go with that right hand where the muscles have been cooled. And you'll see he tries a couple of times. The physician even tries to forcibly open his hand. And it's this problem with involuntary persistent contraction that's a problem with the muscle, as occurs in periodic paralysis, not with the nerve. The other thing I like to point out is, as we'll be reminding you, periodic paralysis, primary periodic paralysis, is an inherited genetic disorder that affects muscle. But the manifestation of symptoms is a combination of that susceptibility, that inheritance plus environmental triggers. So here you just saw cold temperature being a strong trigger, and he was symptomatic with one hand and not the other. I think you can't ask for a more dramatic demonstration of the influence that environment has on muscle function in myotonia as well as in periodic paralysis. So another feature of all forms of periodic paralysis is the risk for eventually having weakness that's irreversible, that's slowly progressive, so-called permanent muscle weakness. The risk of this increases with age. Yes, there are some cases where onset has even been in the 20s and 30s, but usually it's after 50 years of age or so. It's very slowly progressive, predominantly affects the large proximal muscles that are important for things like standing, walking upstairs, getting out of a chair, less so for movements of the hand or fine distal muscles. And curiously, the risk of developing permanent muscle weakness later in life does not clearly correlate with the intermittent episodic attacks that these individuals had earlier. So it does not mean that because you have severe or frequent attacks that you're necessarily going to get permanent weakness earlier or you're more likely to have it. So some individuals, in fact, their only manifestation of periodic paralysis was this late, slow, progressive weakness. And in fact, the diagnosis probably never would have been made except that other family members had repeated attacks that were clearly periodic paralysis. And so just by being able to put this in the context of the entire family, was it possible to make the proper diagnosis. So we'll talk a little bit about this. I'll be here through the whole conference to the end of the meeting. This is one of the biggest concerns of everyone, is the slowly progressive permanent weakness, and so we can talk more about that. So let me just jump a little bit. Those are what it's like to have periodic paralysis. And, you know, it's interesting to think about what's in a name, the name primary periodic paralysis. Primary in some context is replaced by familial, meaning genetic, and it runs in the family. And the adjective is used to distinguish the fact that this is an inherited form of muscle disease with episodic weakness, as opposed to muscle weakness that may come secondarily to other medical conditions. And we'll touch upon that a little bit today. So in primary periodic paralysis, there's a gene defect that's affecting muscle itself. Periodic is actually an unfortunate term because there is nothing periodic about these episodes of weakness. They don't come on a regular cycle. There's no periodicity, but it's there. It's in the name. Paralysis is descriptive and immediately creates a picture of the fact that this can be severe, and so in that sense, it's useful. But as many of you know, or you saw in the videos, not every episode progresses all the way to complete inability to move or contract a muscle at all, which is the formal medical definition of paralysis. So really, it's a variable degree of muscle weakness, which physicians call paresis. So if we were describing this for the first time, I would call it familial episodic paresis, but I wasn't there in the beginning. So it's primary periodic paralysis, but just be aware of these terms and how, in some regards, they can be misleading. So I want to touch a little bit on the biology of periodic paralysis because it's interesting in that although there are many different types that I'll introduce you to in a moment, all of them share a common feature in terms of what's wrong with my muscle during an attack. So this is a micrograph, a view through the microscope. The pink cylinder is an individual muscle fiber, and the thin brown thread coming out of the top is the nerve coming to make contact with the muscle. The nervous system tells skeletal muscle when to contract. So in periodic paralysis, there's nothing wrong with the nervous system, with the nerve, with the way the nerve talks to the muscle. It's with the excitability of the muscle itself. So the whole sequence of events, when to go, when to contract, involves a release of chemical by the nerve ending, but then an electrical response of the muscle, an electrical wave that must travel down the muscle fiber to tell all the molecular elements that it's time to contract. So we can measure it. That's what that cartoon is, the little fine microelectrode we can put inside a muscle. And normally, for this excitation to happen, this graph on the vertical axis is showing the voltage. the membrane potential between the inside and the outside. So your muscle, all your excitable cells, muscle, heart, and nerve, essentially have little batteries of about 1/10 of a volt. And when it's time to signal to do something, contraction of the heart, contraction of the muscle, the voltage very rapidly becomes more positive, the upward movement of that black line, for just a brief fraction of a second, about 1,000th of a second, and then comes back down. And that's the sequence, the brief message that says, go, it's time to contract. What happens during an episode of periodic paralysis, regardless of which type you have, is at the set point, the battery is partially worn down. So, sorry, I don't have a pointer, but on that vertical axis, you see where the number 0 is. That would be when your battery is fully run down and discharged. So your battery partially runs down. You have an inability to maintain the normal voltage across the cell, and that renders your fiber unresponsive to the commands that it's time to go. It's time to have this electrical signal to tell my muscle to contract. And so that will occur for minutes and then reverses. That's how it's possible for spontaneous recovery. And this feature, again, happens with every form of periodic paralysis. So I have about 13 minutes left or so. So let me go through and mention the different types of periodic paralysis. So the one that we hear the most about, probably because the symptoms are a little bit more pronounced, and these individuals often seek medical assistance, is hypokalemic periodic paralysis. So hypo is a term meaning low. Kalemia means potassium in blood. So the potassium in the blood is frequently, not always, but frequently low during a spontaneous attack of weakness. So normally the blood potassium level is in a range of about 3.6 to 5.3 milliequivalents per liter. That's the concentration of the potassium in the blood. And in primary hypo-PP during an attack, it can be anywhere in the low 2s or low 3s. Again, often happens, but not always. When that occurs, that can be very helpful in making the diagnosis. Somewhat more consistent than the potassium being low with a spontaneous attack is the fact that if any events occur that would tend to lower the potassium in any of us. And again, patients with hypokalemic periodic paralysis, they don't have trouble maintaining total body potassium. It turns out, as you'll hear this afternoon, the potassium is just in the wrong place. But events that would lower the potassium in any of us, the blood potassium, such as eating a sugary sweet, which insulin release causes potassium to be taken up by cells. If you have stress and your adrenal glands release epinephrine and adrenaline, that will move potassium into cells. Severe vomiting or diarrhea will cause a big loss of potassium. So any of those events might trigger an episode of paralysis in someone with hypokalemic periodic paralysis. In hypo-PP, the episodes typically begin around puberty, which is later in life than some other forms of primary periodic paralysis, and continue throughout life. They tend to slow down a little bit in middle-aged, and as we mentioned, can sometimes be accompanied by permanent muscle weakness. Importantly, myotonia does not occur in hypokalemic periodic paralysis, and this can be a very important diagnostic clue because, as you heard a few slides ago, it's very important to distinguish what type of periodic paralysis somebody has because minimizing exposure to risks is the first line of intervention. So for someone with hypo-PP, you want to minimize things that are going to raise the blood potassium. But sometimes it's not easy to make the diagnosis, and presence or absence of myotonia can be very helpful in that regard. And that comes up with the second form of periodic paralysis, the second to be discovered, which curiously is the exact opposite. So hyperkalemic periodic paralysis is again an inherited condition in which there are spontaneous episodes of weakness, often, not always, but often associated with elevated blood potassium level during an attack. So it'd be outside the normal range of 3.6 to 5.3, so your potassium might be over 5.5, even as high as 7 milliequivalents per liter. So actions that would raise the potassium in any of us, the serum potassium, such as eating potassium-rich foods, fasting. If you become acidotic, that can also cause potassium to come out of cells. All those events feed into the trigger factors for hyperkalemic periodic paralysis. Just about everybody with hyperkalemic periodic paralysis, if you look closely enough, there's some element of myotonia. For some people, the myotonia is very prominent. It can be temperature sensitive and paradoxically get worse with repeated effort. That's paramyotonia congenita, which completely overlaps with hyperkalemic periodic paralysis. But this can be very helpful, again, at distinguishing what type of primary periodic paralysis somebody has. And the episodes of hyperkalemic periodic paralysis begin a little earlier in life as compared to hypo-PP. That can be another clue in terms of distinguishing what type of periodic paralysis somebody has. The third major form of primary periodic paralysis is the Anderson-Tawil syndrome. It's the most recent to be discovered. It's unique amongst the forms of periodic paralysis because tissues other than skeletal muscle are affected directly. So in Anderson-Tawil syndrome, it's the combination of susceptibility to periodic paralysis, cardiac arrhythmia, particularly with ventricular arrhythmias, and distinctive skeletal features that cause things such as short stature, small jaw, low set ears, curved fingers or toes, go along with the Anderson-Tawil syndrome. Just like you've heard for the episodes of weakness, the features of Anderson-Tawil are extremely variable. So even within the same family, where affected members have the same genetic lesion, some might only have periodic paralysis, some might only have the cardiac manifestations, other individuals may have all three. So variability is a characteristic feature, and again, can make the diagnosis initially a little bit challenging. The potassium story with Anderson-Tawil syndrome is also a little bit more complex than in the other conditions. Most individuals have features that are similar to hypokalemic periodic paralysis. So when their potassium gets low, they become weak. They are improved by administering potassium salts. But others have had spontaneous episodes where the potassium is high. So it can go either way. So it's a little bit tricky, and I'll be happy to answer questions about that if people want to hear more. So, and myotonia does not occur in Anderson-Tawil syndrome. So when you think about these disorders, we've talked about the ones in the middle. There's really, I like to think of a whole continuum, a whole spectrum of inherited disorders of excitability of muscle that on one end, on the left side there, can cause abnormally enhanced excitability, which is the involuntary aftercontraction of myotonia, progressing through to the other side where there are episodes of failure of muscle excitability, which is periodic paralysis. And interestingly, there are some individuals in between, those with hyper-PP and paramyotonia, where the very same individual can have both myotonia and periodic paralysis, which is interesting. So all of these share several common features. As I said, during an episode of weakness, the problem is your battery partially runs down and the muscle is refractory. It's not electrically excitable. And that's why the message cannot travel out through the muscle and say it's time to contract. These are all very rare diseases. You know that. You're all unique. The prevalence is about 1 per 100,000. So for any one of these conditions, there may be 3,000 or 4,000 individuals in the United States with this condition. All of these are inherited as what we call autosomal dominant traits. Autosomal meaning it's not on a sex chromosome, so male and females have equal susceptibility. Although for many women, especially with hypo-PP, their episodic attacks are milder, or they might not have them at all and might only have slowly progressive permanent muscle weakness. The other thing to be aware of is that in an autosomal dominant condition, you have a 50-50 chance with each child of passing on this trait, because only you have 2 copies of each gene, one from mom, one from dad. One abnormal gene in primary periodic paralysis is enough for that individual to have the condition. And the other common feature is that except for Anderson-Tawil, these are all affecting ion channel genes that are selectively in skeletal muscle. That's why individuals with periodic paralysis, these gene defects, these electrical problems, do not also directly affect the nervous system or the heart, except for Anderson-Tawil syndrome. And so it's a little cryptic there, the designation, but on the left, myotonia congenita is a chloride channel problem, big group of different conditions that are all sodium channel problems. So as a medical scientist, it's really interesting to understand why mutations in one gene, the skeletal muscle sodium channel gene, can cause so many different clinical syndromes with variable presentation. Hypokalemic periodic paralysis can either be a sodium or a calcium channel defect, and Anderson-Tawil syndrome is a potassium channel problem. So I want to touch upon, because the Invitae test and a lot of other gene tests, I get a lot of questions about other genes that might influence the susceptibility to periodic paralysis. There are a few extraordinarily exceptional cases. So really the ryanodine receptor, which is a huge protein, it's the calcium release channel, because it's so big, by chance, there's a greater probability there'll be a variant in that gene than other genes. And there really have only been, to my examination, 4 cases of periodic paralysis in the entire world that can be attributable to a variant in the ryanodine receptor. And 3 out of the 4 were inherited in a recessive fashion, and there were other features of muscle disease, myopathy. So yes, these individuals had fluctuating weakness, but otherwise it was very atypical for periodic paralysis. So if you have features that are more typical of periodic paralysis, this would be an unlikely scenario for the cause of your symptoms. There was another mutation found in not a channel but a pump that sets up these differences in salts between the inside and the outside of the muscle. One patient in the world with a mutation in this pump causing periodic paralysis and also with seizures. So again, it was atypical. So again, happy to help you through this journey, but it's really the main genes, the SCN4A sodium channel gene, the CA-CNA1S calcium channel gene, and the KCNJ2 potassium channel gene are the 3 big players for primary periodic paralysis. So I have about 2.5 minutes left if I'm on time here. I know with the streaming, we need to stay on time. And I want to use the remaining time to touch on an interesting and controversial topic with regard to type of periodic paralysis, which is normokalemic periodic paralysis. So many individuals have episodes of weakness. You go to the emergency room, my potassium is normal. Your physician says, this can't be periodic paralysis, your potassium is normal. First of all, that's an incorrect statement, which we'll get into a lot this afternoon. But on the other hand, there's a temptation to say, oh, I must have normokalemic periodic paralysis because I keep going to the emergency room, my potassium is normal, but I am weak. Well, the whole story of normokalemic periodic paralysis started by this publication in 1961. So 2 physicians in the United Kingdom saw this large family. This is a family tree. Each row is a different generation. So there are 1, 2, 3, 4, 5 generations in this family. The filled symbols are affected individuals who had what they thought was an unusual form of periodic paralysis because the potassium tended to be normal. And so they wrote up this paper. Hey, there's a 3rd type of periodic paralysis, hypokalemic, hyperkalemic, and normokalemic. But when you look at the details in this paper, okay, some of the episodes come with rest after exercise or stress, that's fine. Some came with drinking a particular local beer, which was very high in potassium. And potassium loading caused weakness in some of these individuals. And so there was a follow-up 40 years later, once the genetic tools were available, and Mike Hanna's group in the United Kingdom found this family, showed they also have myotonia. So myotonia often goes with hyper-PP. And when they did the gene testing, this index family, 5 generations, this is the sine qua non, this is normokalemic periodic paralysis, that's the 2nd most common mutation in hyper-PP. So normal-PP is hyper-PP from my perspective. And there are other examples. There was a paper published by Bertrand Fontaine's group in France, a series of mutations curiously all at the same location. I apologize, it's cryptic. I have 15 seconds left. But they were 9 patients, but many of them had features of hyper-PP. And there are other descriptions of the T704M mutation. Hyper-PP, the most commonly occurring mutation, half of the patients reported did not have any change in potassium at any time when they went into the emergency room. So please be aware, even though you have a potassium-sensitive form of periodic paralysis, the potassium level might not be spontaneously abnormal, even while you're weak, while you're in the emergency room. Stay open-minded about that. I would also say that same thing happened for M1592V. Especially if you have recurrent episodes of weakness, but your potassium is always normal, you got to be open-minded. It could be any form of periodic paralysis. But if you also have myotonic involuntary contraction or myotonia on an EMG, then you certainly have a variant of hyperkalemic periodic paralysis, and that's what's going on. So I'll end there. We can just skip through this and offer, if we have time, answer any questions individuals might have. Thank you.
So we do indeed have time for questions, and we've got a couple of systems that are happening simultaneously. One, if you can make it up to the mic, you're welcome to come up to the mic and ask your question. We're asking that all of them be kept within a minute so that we can do that. And we have about 15 minutes set aside after every speaker. You can write your question on a card and hold it up, and somebody will bring it up to me if that's easier for you. And then online, we're at Zoom and on Facebook live streaming, and so we're trying to focus the question asking on Zoom. That doesn't really affect you in the room, but for those that are listening. So please use that feature, and then I've seen a couple in Facebook, and we'll try to get those. So Dr. Cannon, thank you very much.
Sure.
And we'll start with this one from the audience. Are your references to normal potassium readings in emergency room with or without a tourniquet? Does that make sense?
Yeah. So I'll repeat the question. So those cases in which potassium is normal in the emergency room, is that for blood draw with or without a tourniquet? And when this question is touching upon, and we'll go into this in detail this afternoon, is many artifacts can come into the measurement of blood potassium level, one of which is the duration in which the tourniquet has been on. Another is how difficult it is to withdraw the blood. If the red blood cells get burst open, the potassium can be artificially high. So I would have to say that in the majority of cases, that level of detail is not known. But I would follow it up with saying under very well-controlled situations where individuals were brought into the National Institutes of Health and watched for days and weeks, careful measurements have documented that it is clearly possible to have an episode of severe weakness, whether you're a hypokalemic or a hypo or hyper, and at that time your blood potassium is normal. And we'll go into this a little bit more this afternoon.
All right, thank you. And we have a question here.
Dr. Cannon, it's good seeing you again.
Yeah.
One of the questions I wanted to ask is, has there been any more research going forward, again, with the sodium? Like, I myself am hypo. I know some people are hypo that I crave sodium, had to have sodium. I sweat it out, and I have to replenish it. But then on normal days, I still would crave it. Then some people can't even touch salt, can't even do sodium. Has there been any research going forward with that throughout the years?
Yeah. Great question. We have to think carefully about, there are many different salts. So potassium is one, sodium chloride is the other. And it was recognized many years ago by patients and their physicians that the amount of table salt you take in sodium chloride can influence risk of attack, susceptibility and attack. And so how can we make sense of this? We've been talking about potassium-sensitive clinical syndromes here. And what I can say is, first of all, it's a very consistent finding. Secondly, in our animal models, we can show that when you increase the sodium and you have hypo-PP, it actually puts you at risk because of the way the muscles respond to the salinity, which is called the osmolality of the serum increasing. So if you get dehydrated, either because of high sodium or high glucose, if you're diabetic, those turn on a sequence of events that lead to greater susceptibility. So many individuals, we advise them to hydrate, not get dehydrated with exercise, and be careful of salt. But we all have to be humble as medical scientists. When somebody comes up and says, I feel better when I take salt, we need to look into that and understand. But what I will say is, too much salt, being dehydrated, we have a good explanation, biomedical, for that piece of it.
The reason why I asked that is because I live here in Florida, I sweat a lot. Through the age, my potassium, my salt, sodium fluctuates. I get potassium, I still ate, I get more salt, sodium, maybe like a Gatorade or something like that.
Yeah. So just so those online can hear, the follow-up comment was, as a resident of Florida, you perspire a lot, and you lose a lot of salts in perspiration, particularly sodium. And if your sodium you can get muscle cramps and strange things happening if your sodium gets low. So without knowing the exact numbers, I would certainly agree. And athletes, people who have to do physical work outside all day long often take salt tablets, and they will feel better. That's not related to periodic paralysis. That's because in any of us, if your sodium gets too low, you're going to start to get cramps and not feel well. So, yeah. Sure.
All right, another question for the audience, from the audience. Are longer attacks, 2 days plus, a sign of permanent muscle weakness starting? My attacks used to only last a couple of hours or less, but as I've gotten older, they're lasting longer. I'm in my 20s.
Yeah. Great question. So the question is duration of attacks, and as they get spaced out and longer, does that mean I'm approaching inevitable permanent muscle weakness? What I would say is there's a recognized pattern that with age over decades, the episodic attacks often are less dramatic, so the maximum weakness isn't as bad, but they last longer. They begin lasting days or even weeks. And what I can say is that's part of the natural progression and history. It's hard to say whether that is necessarily an indication of inevitable, very soon to be occurring permanent muscle weakness. And the reason I say that is because if you look carefully enough and quantify someone's maximum force and effort and follow them over time, many very good, well-qualified neurologists, Birch Griggs and others, say up to 80% of individuals with periodic paralysis will eventually have some element of permanent muscle weakness. So because it's such a high proportion, it's difficult to attribute any one feature to that risk because everybody is at risk. So it makes it difficult to be more specific.
Thank you. Another question, is there a theory or physiologic reason why females are less symptomatic?
Yeah, so that's a great point. The gender difference is most consistently observed for hypokalemic periodic paralysis rather than hyper. And this was identified in the 80s and very nice study out of the Netherlands. Teresa Link's huge family that ends up having the R528H calcium channel mutation and hypo-PP. And there the story was, this was even before gene testing. Many women in this large family never had a recognized, that's important, recognized symptomatic attack of weakness. And yet later in their 40s and 50s, they began to get permanent muscle weakness, difficult walking upstairs, and so forth. And so that was the origin of, there's a gender difference. Women tend not to have as severe episodic attacks. Again, once gene testing became available and you could really see who's at risk because who carries the mutation, that's been even further strengthened, and it can complicate the genetics. And trying to think, does this trait occur in a pattern in my family that's consistent with being autosomal dominant, which is one of the criteria to establish a clinical diagnosis. And individuals might think, well, it skipped a generation or it doesn't make sense, but that's because the women didn't manifest symptoms, and it can make teasing that apart. I'll just finish up with saying that we have made 4 different mouse models, genetically engineered mouse models of periodic paralysis, one of which is the hypo-PP R528H mouse. It's the most common cause of periodic paralysis. And the female mice do not have as severe attacks as the male mice. So it's a very real biological effect that we just haven't had the time to get to the bottom of it.
Okay, we've got about 8 more minutes and 5 more questions. We'll see how we do.
All right, I'll go fast.
In Anderson-Tawil syndrome, can potassium levels go both low or high in the same person?
Yes, so there are reports of individuals with spontaneous attacks of weakness associated with either high or low potassium. It's happened.
Good. This is like rapid fire. Can you have more than one form of PP?
No, so periodic paralysis, again, is a familial disease because of well-defined gene defects that impact the way ion channels behave. And while there is variability in the symptoms, they never, in my experience, cross over to the point where someone can have both hypo and hyper, for example. Now, the caveat is Anderson-Tawil syndrome, it's a little bit more confusing, but there are other features, the cardiac and the skeletal, so that's a clear clinical entity. But classical hypo and hyper, you shouldn't be flipping back and forth between either. I've never heard of a case of lightning striking twice and one individual having a hypo-PP mutation and a hyper-PP mutation.
The doctor says I have hyperkalemia, but have had instances where I was weak and the potassium was low. Does that mean I'm hypo?
Yeah, and so as we'll get into more this afternoon, all of us have normal fluctuations in potassium. And by chance, somebody's might have been low, could be rebound while they're getting over an attack. And so, there's a lot of focus on potassium because, early on, as doctors were trying to help patients and sort this out and were there really two different types, the only handle they had was the potassium. That was the only objective measure. So understandably, a lot of focus was placed on classification according to potassium, and it still is consistent, and it's very important in terms of management and minimizing risk. So all those features are key, but there's a lot of variability, and that's why relying on blood potassium alone is usually inadequate to confirm a diagnosis or exclude a diagnosis of periodic paralysis, and most emergency room physicians don't appreciate that. So.
When talking about myotonia, does that include involuntary muscle contractions during attacks? Muscle contractions are usually 5 seconds to about a minute and only during attacks.
Yeah. So myotonia fluctuates just like periodic paralysis. The fluctuation is very dependent upon recent level of muscular activity. What we tend to see is people with hyper-PP might begin to have more prominent myotonia as they're beginning to have an episode that's going to progress to weakness and paralysis. And then as they come out of the paralysis, their myotonia might be, again, more severe than baseline. But the myotonic stiffness and involuntary contraction eventually relaxes in 10 or 20 seconds, but it will occur again the next time you contract. But if you do it repeatedly, it warms up and eventually gets better.
This gentleman has a question.
Sure.
Hi. I might pronounce these wrong. Looking at the neuromuscular junction point, when all this fires off as a sodium channel, if you have the ligand-gated channel first where the acetylcholine hits, that sodium first goes down, and then you have the voltage-gated sodium channel. Do we know which channel, or is it both channels that are being affected?
Yes. So great question. Let me help everyone. So when you look at the biology, the ion sodium plays many different roles. Sodium coming into the cell is what makes the voltage go more positive. And as you heard correctly, when the nerve talks to the muscle, it releases a neurotransmitter, a chemical, acetylcholine, which binds to a receptor. When that receptor opens, sodium comes in. Sodium is coming in, but that's not a sodium channel. That's the nicotinic acetylcholine receptor. When that sodium comes in, it starts to make the fiber become more positive, and that small voltage opens voltage-dependent sodium channels that then open and allow more sodium to come in. It's a positive feedback, and everything takes off. It's that second type, the voltage-activated sodium channel, that's the problem in both, primarily in hyper-PP, but also some rare cases of hypo-PP.
Okay, and we've got about 3 more minutes. Just reminding the folks on Zoom that they can chat their questions in. We'll get through the ones that we can get. You'll be back twice more today, so I'll hold the ones that we don't get to this round and get them out to you at a subsequent. Is it common to have a hard time building up muscle mass due to limits in exercise tolerance?
Yeah. So an interesting question. Should you be in a vigorous program of exercise, whether it's aerobic or trying to build bulk for someone with periodic paralysis? I would say that has to be tempered by your response. So I knew a young individual in Boston, a young guy who would go bench press, 260, 280, and because he was going to work through his periodic paralysis. But he would go home and rest on the couch afterwards, and his chest muscles would become flaccid and you don't want to do something like that, okay? So I advocate activity and exercise to tolerance. We talked on prior years of this conference, we're beginning to get some understanding about why exercise is a risk factor for triggering an attack. The punchline is stay well hydrated first, warm up, but most importantly, warm down after the period of strenuous exercise. So spend 15 or 20 minutes slowly walking, light exercise. That will help prevent one of these post-exercise triggered attacks of weakness.
Some of my worst episodes have been related to the start of my menstrual period. Is this something you can speak to?
So variation in risk of attacks in relation to the menstrual cycle has been reported many, many times, as well as changes with pregnancy. We heard a little bit earlier there's a gender difference. These are all very real. We don't have the exact handle on the biology of why that's happening, but individuals can take advantage of that knowledge to prepare and maybe adjust their medications in relation to their cycle to try to get better protection. But it's certainly a frequently reported phenomenon.
Let me end on this one because I think it might be a short answer for you. What kind of specialist should I see for hypo?
For any form of periodic paralysis, I advise you to go to a neurologist, and in particular look for someone who's qualified in neuromuscular medicine, because neurologists deal with stroke, Alzheimer's, epilepsy, all kinds of things, but there's specialty training in neuromuscular disease, and those individuals will be familiar with the diagnosis and management of periodic paralysis.
Thank you so much. Thank you, Dr. Cannon.
Thank you.
If you would like to know more about periodic paralysis, visit periodicparalysis.org. And if you enjoyed this video and want more, hit that like button, subscribe to our channel, and hit that bell so you don't miss any future videos. It really does help spread the word. You can view other videos about periodic paralysis by clicking the thumbnails to the right. If you have questions, just leave a comment below or reach out to us on social media. We'd love to hear from you.